This is a riveting topic about a disc prep quality. Although I learned something making this talk, I found some, reviewing the literature, and I found some things that changed what I'd always accepted as dogma. And so when we talk about disc prep, really, what's our goal? We want to achieve a solid fusion. And generally speaking, we worry about disc prep when we're using interbody devices and grafts. And this talk's not about the device or the graft, but basically, why do we like to put things in the disc space? Larger surface area, anterior column support, and increased fusion surface, correct the deformity, indirect decompression. The one on the left, doesn't matter, doesn't have to be a cage. The one on the left I use femoral ring allografts for, and the one on the right was a more traditional ALIF and P cages. But the whole thing is predicated about getting a fusion through the anterior column, so you need to have an appropriate preparation of the disc space. So doing the literature review, this was a pretty nice paper. Jeff Ryan wrote this with the folks at Jefferson, I don't know, about 10 years or so ago. And this is a caveat. When I went through the literature, almost all the studies were cadaveric. Remember, when you're operating, we've all operated on cadavers. There's no bleeding. We're generally not as worried about a durotomy. And so I would argue doing a disc prep in a cadaver is pretty much probably your best disc prep you'll ever do, right? And so what was interesting was they compared MIS, a minimally invasive approach, versus a traditional open TLIF. And long story short, there wasn't a huge difference in the amount of disc prep. They both achieved adequate disc prep. What they found in both techniques was, I don't know, well, I guess me using a laser point on the screen there is not going to help you all, was that it's that far posterior corner, both posteriorly, anteriorly, and posteriorly. When you get to the far contralateral side, anteriorly and posteriorly, that's where we always struggle. And that's where, like, when I actually do more T-lifts than I used to, that's where you've got the wobbly high neck curettes and you're out there really scraping the cartilage. And that's where we struggle with our disc prep. And that's also what they found as well. But if you look at it, they divided up by quadrants. They got pretty much, close to 70, 80% of the disc, over 70% out of all three quadrants, except the posterior contralateral. The posterior contralateral, both MIS and open, they got around 60% open, 50% with MIS. So that's the area where when you're doing your procedure, you really need to focus with the wobbly high neck curettes and just really feeling yourself scraping that bone, but not going through the end plate. But all in all, it wasn't statistically significant except for that corner. And the other thing that I thought was a key take-home point of this paper, and this is what I'm always reminding my fellows, doing disc prep doesn't just mean jam in the shaver, spin it a few times, and put in your cage. You need to take time and do an appropriate disc prep, both to get all the disc out as much as you can, and also so you're not cracking the end plates. And in the easiest, best discectomy you ever do, which is in a cadaver, so you're not worried about bleeding, you're not really worried about, the dura is usually deflated, right, because they cut the spine to give you the specimen on the table, so the nerves aren't in your way for the most part. It took them 12 minutes, MIS, and average about 9 minutes open to do this adequate discectomy. So in the OR, it's going to take you longer than that. And so if you're doing your disc prep in 5 minutes, you probably, unless you're really, 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 really good, you're probably not getting adequate disc prep. And so that's the part of the case. You've done your decompression, you've got your nerve root retractors in. This is why I always tell the fellows, this is why we're here. This is the important part of the case. This is not the part of the case to rush. Take your time. And, if you're doing it in 12 minutes in a cadaver, it's going to take you longer doing it open if you want to get the results that they had here in their cadaveric study. But it is pretty clear, MIS takes longer. Either approach, you get between 75, 80% of the disc removed. So then what about if we add navigation? So this was another interesting paper I found. I did a search for that. I found like 7,000 papers, but only like 6 of them are worth talking about. I didn't read all 7,000. But the anterior approach with or without navigation. So they did an ALIF, and this I found interesting. This was with going in and taking out the discectomy in the quadrants. And again, if you look here, it's the anterior to psoas approach, it's that far lateral corner where we struggle to get the disc out. So it's the same thing as the TLIF, except the person's supine, so it's opposite angulation. And they really, really struggled doing it that far corner. And then with navigation in that one corner, they were able to get a better rate of discectomy. But either way, with or without navigation, you get a decent discectomy amount out. But the thing that was interesting here, again, look at the time of the discectomy in a cadaver. And on this one, the time is, where's the time? Operative time, 17 minutes. 18 minutes really with fluoroscopy, 17 minutes with navigation. So in a cadaver, doing that quality disc prep took them roughly 17 to 18 minutes. So again, this is the part of the case where you slow down. This is why you're there. You did all that hard work, digging ditches or whatever else you're doing to get to the 5-1 or disc. It's a lot, you're tired, you got your screws in, you slow down, you're not done. You take your time for the disc prep. Otherwise, everything else you did was in vain. And then we look at different approaches. In this paper, I actually found somewhat surprising. So what's the quality of discectomy anteriorly versus posteriorly versus laterally? If you had asked me before I made this talk, I would have said it's a no-brainer. ALIF, you get the most discectomy. And I still kind of believe that, but that's not what the literature showed, at least this study. Their worst discectomy was an ALIF. And probably not, it was a mini ALIF, but I guess it depends on your access surgeon. You got the vessels there, and it may be you're a little bit less aggressive with the curettes. When I do my discectomies and ALIFs, I like a big curved lumbar curette, and I get in that back corner and scrape and deliver the disc to the front. But that's the point also where you get the backside vein injury if your curette pops out of the disc space. So I don't know if maybe this group was a little bit less, wasn't a cadaver, so they probably weren't that worried about the vessels. But the point is, I was shocked by this, but in this paper, mini ALIF had worse discectomy, disc prep, than all other techniques, and the lateral had the best. And it wasn't, I don't know if it makes that much of a difference clinically, but I was surprised by this. And the take home from this was ALIF and PLIF had the most insufficient preparation, and that makes sense, I guess, for the PLIF because of the way you do the neuroelements. And TLIF and XLIF, or far lateral, whatever acronym you use, whatever company you like, had the best disc prep. I was shocked by the ALIF. I don't know if I believe it, but that was a nice study, and that's what they found in their study. So I like this one because this is a retrospective clinical study. So this is where people are actually in the blood, in the CSF, dealing with the nerve roots, and they went back and looked retrospectively with CT scan at what was the interbody bone graft available and what was their fusion rate. And was there a difference between minimally invasive and traditional open TLIF? And basically, take-home study, there's not a difference in the fusion rate, but this is really sobering. And again, I would keep one of these a laser pointer on the screen you can't see. The fusion rate was 80% for the open group and 82% for the MIS group. And the p-value is not statistically significant. But anytime you ask me, or any other surgeon probably, what's your fusion rate when you do a TLIF? We all say, oh, 90, 95%. Oh, no. If you really look at it critically after the fact, the fusion rate's pretty sobering. We're not as good as we think we are with these procedures. Now, I would argue, does radiographic fusion rate correlate with outcome? It's probably more your patient. If you don't go back to the OR and the patient's doing okay, it's probably a win from the patient's perspective. But I found that pretty interesting. And also, this was autologous local graft with some DBM and a peak cage. But the fusion rate was sobering, and but other than that, there's no difference in the quality of the discectomy, MIS versus open. So discussion, overall, there's no significant differences between the approaches. I would argue if you've got a confident access surgeon getting you a nice exposure and you're confident, I personally think ALIF's the best discectomy, but in the literature, it wasn't, at least a 5-1 with a mini approach. Lateral arguably is a little bit better discectomy in some of the papers. All these things doesn't really have any difference in the clinical outcomes or the fusion rates with any of these techniques. So really the key thing, proper disc space preparation takes at least 10 minutes in a cadaver where you only have half the spine, it's cachectic, the dura is deflated, there's no bleeding, it takes 10 minutes. So if you're doing it faster than that in your OR, I would encourage you to slow down a little bit and work on that contralateral corner. Now, thank you, I'm out of time, and appreciate everyone's attention.